Gil Bash. I'm Chair of Global Health and Purpose at Fin Partners. It is a privilege to facilitate this session with one of our nation's outstanding health policy thinkers. I'm with David Farber. David is a well-known partner at the Washington headquartered firm King & Spalding. It's a global policy firm covering many different areas. Of course, one of its strongest areas, and David is a leader in that group, is its health policy organization. Health policy also includes its work within the Beltway on Capitol Hill. And David has probably one of the most important roles to the health innovation sector. He is really the conduit that makes innovation accessible to physicians and patients. I say that because David is probably one of our nation's top experts from the policy side on aspects of Medicare and Medicaid, which serve a vast majority of American citizens, citizens who are 65 plus, and those who are in need of access to care. Obviously, David also deals with private reimbursement issues, but his work on the Hill obviously is nationally known for his understanding of health policy within the Center of Medicare and Medicaid Beneficiary Services, obviously now led by Dr. Mehmet Oz, and of course his work in HHS, led by RFK Jr., and his work on the Hill with the Senate Health, Education, Labor, and Pensions, and of course with the House Energy and Commerce Health Subcommittee. David has really been a source of information, a source of counsel to both industry and members of Congress. And David, I want to thank you for returning to us again this year. It's a pleasure to have you. Obviously, you have an illustrious academic career, your work at NYU, New York University, obviously your law degree from Georgetown, prestigious firm there, and then obviously you've served in quite a few of Washington's most prestigious health and lobbying firms, and now have the position that you have as partner at King & Spalding. I want to thank you for returning to us. And I just want to kick off our discussion. You were with us last year, of course. The administration was relatively new. It was looking at some very key aspects of regulating innovation, of how health policy was going to reshape the future of health. And you offered us some pressing, ominous, concerning predictions. So looking at your magic 8-ball, how did you fare in guiding us last year compared to where we are right now?
Thank you, Gil. It's a great question. But first, thank you for that very generous introduction.
All true, I'm happy to say.
Were my mother only alive, she would have been really happy to
She's
hear all
listening
this.
to us from above, I'm sure.
Right, so no doubt. But thank you again, and thank you for having me back for this conversation. Just the usual lawyer disclaimer: the comments today are my own; they're not my firm's, they're not our clients. But again, just thrilled to be here, and thank you for inviting me to talk about this very important topic of health innovation. So let's go back to your question. Where were we a year ago? What was I focused on a year ago when it came to regulating innovation and how policy is reshaping the future of health? And was I right or was I wrong? There's a favorite saying of mine in Washington: those who gaze into crystal balls end up chewing ground glass. And
Ouch.
that's probably true here. But let's go back a year and think of where we were relative to where we are now, because I think it is informative. So really, last year we began this conversation just as the DOGE reductions in force were winding down. And that was a huge shock to Washington and had a particular effect, across many of the agencies within the Department of Health and Human Services, not CMS, which was sort of was spared those cuts, but that's what everybody was reacting to. NIH, FDA, there was a lot of focus on the DOGE reductions. There was also a huge amount of focus on NIH funding being cut. There was a fundamental reshaping of the policy conversation in Washington that continues to till now about what I will call DEI issues and health disparities that have been a key feature of the Biden administration and the Trump administration a year ago entered into the conversation and said we are done with that and we'll talk about what happened there. And then last year at this time the administration was really just getting its nominees in place. I think by this time RFK had been gone through the nomination process, survived the vote with Senator Cassidy, and we can come back to that. Dr. Oz wasn't yet confirmed, and a lot of the senior staff, some were there, had gotten there as part of the landing teams in right after the election. Others were still filling out. A lot of the political appointees were not yet in place. So there was a lot of uncertainty. And frankly, one of the things I focused on last year was the impact of the staffing cuts, particularly at NIH and FDA, and the potential risks to innovation that came with that, and the significant reduction in funding at NIH, and research grants being cut all over the place. There certainly was cause for concern. A year later, I think some of those effects are still only now being really appreciated, the staffing reductions and the filling in of staff, particularly at FDA, which is a focus right now, were likely warranted. NIH funding has been cut. Lots of grants were terminated. On the other hand, and this is some of the good news, that Congress was not as excited about the administration as about reducing NIH funding. And Congress, in its appropriation process last year, that really only wrapped up a few months ago in February, was much more generous to NIH and filled in some of that funding pipeline. That's not to say that many studies weren't interrupted. They were, and there will be a long-term price to pay for that, particularly with regard to innovation. That being said, Congress had NIH's back, and although the money is not flowing as smoothly and as freely as it should be, and new grants aren't being funded, as easily as they were before, there is the funding there, even though it may not be quite as robust as it was previously.
So David, it sounds a little bit like your predictions were more cautionary tales from last year, and that these were things we should keep a close eye on. But as Washington is best known, the administration has declarations, and then Congress has its own points of view. So it sounds like, to some extent, even though there is a Republican-controlled Congress, that there was some sense of checks and balances that went on in terms of the continued support for the departments of HHS, and that some of the historic or priority programs have continued, and in quieter ways, perhaps. So that brings me to the present. I mean, you gave us a very good snapshot of where we were a year ago in terms of this administration. As always happens with the new administration, it's a bit older, albeit 1 year from last year. It's a bit older, a bit wiser. It's starting to understand the bumps in the road with dealing with appropriations. It understands where it has to set its priorities. So what is the approach or policy now that's shaping the future of our health sector? I mean, a lot of the tone and to some extent the tumult of what happens in Congress and from the administration itself creates a sense of focus and clarity for the innovation industry. What are we looking at right now as you and I speak on this wonderful Monday afternoon in May?
Sure. Tying back to some of the specifics of what I was talking about last year, ironically, and this just happened this week, HHS and CMS in particular are now hiring 1,200 new employees. So, a lot of the staffing changes are being reversed, and the mayhem of Doge cuts last year is being forgotten. But that's not what I really want to talk about in answer to your question. I just couldn't resist adding that point. In answer to your question, what are the primary policy drivers right now? I put them into three buckets. The first is waste, fraud, and abuse. And we have seen the Medicare program and the Department of Health and Human Services generally really double down on waste, fraud, and abuse. Dr. Oz has announced the CRUSH program, which is a fraud detection and enforcement program. There is a lot of activity, principally focused on blue states, Minnesota, California, New York, on trying to eliminate waste, fraud, and abuse in those programs, and particularly in their Medicaid programs. But this administration is, and there's also, the adoption and embrace of AI to go after waste, fraud, and abuse. There are arguments on both sides. Some say it is long overdue. Some say that the aggressive posture, an aggressive pursuit of waste, fraud, and abuse is going to end up, resulting in a lot of denial of care. The administration has, and they announced this a year ago, so they call the WISER program, that is applying AI tools to review claims as they come in. Secretary Kennedy was in the Congress last week and got a lot of questions about the use of AI in over denying care, for Medicare beneficiaries trying to get through the system, and that will have an impact on innovation. And we ought, call it out and recognize it. When there is this clampdown on waste, fraud, and abuse, there are inevitably unintended consequences and innocent victims who get caught up in these enforcement efforts. And companies that are out there trying to innovate, I have several therapeutic areas I'm thinking of, sort of dial back and wait till this wave is over. And those are just lost years of healthcare innovation and treatments that are going to be delayed for patients in need that could have gotten there sooner, but for these efforts. I'm not saying that we shouldn't support the aggressive enforcement and rooting out of waste, fraud, and abuse, but there needs to be a balance between the aggressive pursuit and the cost on the innovation side, and we need to be sensitive to it. And there are some in Washington who believe that the policy focus right now is not in balance. The second area of focus for the administration is cost reduction, and we are seeing multiple efforts across almost every aspect of healthcare to reduce costs. You could put this in the affordability bucket, which is going to be a political theme for both parties in the upcoming election. But cost reduction is happening all over the place. And the reality is that the Medicare Trust Fund is at risk of running out of money. Not that it's going to run out of money, but that the benefits may need to be scaled back because there won't be the money to fund the benefits on an ongoing basis. That too has an impact on innovation. To the extent that there is not robust funding for new technologies and that there's payment for the R&D and all the work that went into bringing these new technologies to market and to bringing them to patients. Again, when manufacturers, innovators pull back, and we'll see how that comes into balance. On the positive side, however, there is a singular focus on technology expansion and innovation in both new treatments and in new technologies to get them to patients sooner. The Center for Medicare and Medicaid Innovation, CMMI, or the Innovation Center as it's called, is fundamentally revamping and experimenting in ways that CMMI has not tried before since it was created under the Affordable Care Act in 2010. we're seeing all sorts of new models coming out of CMMI that create playing fields for the use of new technologies and the use of innovative approaches to treating disease and to curing patients. And we'll see also how that plays out. I was talking to the director of CMMI a few weeks ago, and he was very candid with me. A lot of CMMI models over the course of the first 10 years of the program, 12 years of the program, have failed. They just haven't succeeded in either saving money on existing treatments or improving care at the same cost. This administration is very focused on changing that to find real ways to both save money and improve access to new technologies. And I think that is a very exciting opportunity to expand innovation in the healthcare sector. Excuse me.
Yeah, I've seen, of course, we've seen a lot of news about the Food and Drug Administration's embracing the new AI policy. I mean, just staying where we are right now. I mean, you look at this from the 30,000-foot level. You look at this from the 3-foot level. Obviously, at the 3-foot level, we see this. I would say this consistent love affair with clipboards and fax machines. Obviously, we constantly pledge to a bid adieu to the fax machine, but hospital systems still have banks or rooms of fax machines to serve their need. There must be, I guess, a fax machine lobby working very hard in Congress, or the clipboard lobby obviously is spending more money than other industries. That's my assessment right now, since I keep on having clipboards thrust in my face at every doctor's visit. But you're close to some of the programs that are now sort of being implemented that transforms the health system, that transform even how agencies will look at I'll call it smart embedded technologies, wearables that transmit information, tools that allow patients to be in touch with their health provider, others that collect information, ambient sound technology that exists in hospital rooms so that doctors actually look at their patients again instead of at a laptop on a wheelie cart in the office. All of these are, I know, driven by policy, Beltway policy. What are some of the programs on your radar screen that you think we should know about that will impact industry?
Yeah, it's a great question. Let me highlight two that I think prove the point that I was making a moment ago about the expansion of innovation opportunities and technology expansion. The first I'll focus you on is a program that's maybe 4 or 5 months old, but we've never seen anything like this in the Medicare program before. That's the CMS AHEAD model. So the AHEAD model is built to use AI and remote monitoring technologies and encourage their adoption when tied to outcome-based enhanced payments in specific therapeutic areas. So the AHEAD model is not available to anybody in the healthcare arena. There are 4 or 5 specific therapeutic areas where companies with innovative technologies, with AI or other remote technologies, could apply to the Medicare program. The manufacturers have to register as Medicare providers. We have not seen in a long time. It's a very interesting opportunity, for those companies who have begun the program and those who will, to get into the Medicare program with their innovative technologies, prove that there is an increase in outcome-based health improvements and get paid for doing it. Now, back to what I said a few moments ago, the payment is not huge. It's like $40, $50, maybe $50, $60 a month for the use of these technologies. If they prove that they can increase health outcomes in the specific therapeutic areas. So, it's giving everybody skin in the game, but, we've never seen anything like this. The program has proven to be so successful. CMS announced just a few weeks ago that there are over 120 companies that have already been qualified. And although CMS set a deadline of early May, it has now expanded that deadline because it's had such demand to participate in the AHEAD model. So we should all keep our eye on the AHEAD model, how it succeeds, whether it succeeds, how it succeeds. But it's a great example of how this new policy approach and the administration's willingness to take some chances, with these new and emerging technologies, wearables, AI, and other, are finding that intersection of the rubber hitting the road and are actually being put into the field. And there is Medicare funding available for those manufacturers who participate in the program. So watch ahead. The second is a more recent announcement, literally an announcement over the course of the last week, where FDA and CMS have announced the RAPID program, which for 40 breakthrough medical devices a year will allow fast tracking both through the FDA, and as soon as the product is approved by the FDA, it will or cleared or whatever, it will be covered by Medicare, and it has instant access to the market for breakthrough medical devices, but not only breakthrough medical devices. This has been a challenge. Medicare, FDA clears these products as breakthrough. Medicare is suspect about covering them because there's not a large body of evidence showing whether they're reasonable and necessary. And there have been multiple attempts over the last decade to get these breakthrough medical devices through the process, get them through FDA, which has not been the problem, but then get them covered by Medicare. Now, I should caution that we don't have all the details of the RAPID program yet. There will be announcements coming out very shortly. Medicare already has a program like this for breakthrough medical devices. It's very similar to something called coverage with evidence development, which I personally am not a fan of. It only is because of bandwidth issues. Only five devices a year make it into the existing program. There's something called MSET. There's something called TSET. But this is taking that program and multiplying it eightfold. That's only getting from 5 devices a year to 40. And many of us are suspicious, whether this administration will be able to pull off the RAPID program, because FDA and CMS have tried to coordinate, fast track and not fast track, excuse me. There was another program, now losing the name of it. But for the last 20 years, there have been efforts to sync up FDA and CMS. None of them have really succeeded, in my view. In fact, I often tell people with innovative devices, don't go into these programs because you risk slowing down.
So I have to ask a question about this. Particularly when we take a look at the RAPID program, and historically private payers have been slow to put medical devices on formulary. They sort of even if it's used in quite a few people, sometimes they'll say insufficient clinical evidence. Will the experimental? Will CMS agreeing to put them on the formulary for Medicare patients cause some conflict with private payers? Here you're having Medicare say we greenlight these 40 devices. What happens on the private payer side then?
Yeah, I mean, I think the commercial players follow Medicare, that's usually what happens. Although in some of particularly the remote monitoring technologies and the remote therapeutic programs, we're seeing Medicare expand coverage and the commercial payers contract coverage. So that Gil, what you point out absolutely is a risk. But the hope is, and the White House is very effective at communicating this, both with carrots and sticks to the commercial insurers. But if Medicare is going to cover it, the hope is that the commercial insurers will cover it.
I've got in the time we have left, I've got to ask the white elephant in the room question. We have interim elections coming up in a few months. Obviously, highly contested seats are at play. We right now have a Republican-controlled House and Senate. Um, what do you think is going to affect the policy landscape?
Yeah, so it's a great question. The presumption is that the House will likely go Democratic. More of a question about the Senate, and no doubt that will bring change. You know, but a lot of the innovation that we're talking about here is really within the executive branch. Congress has a difficult time legislating innovation, not because they don't want to, and not because there aren't dozens of bills that are trying to do so, but that costs money and it's hard to pass bills that cost significant amounts of money through the Congress. CMS has a lot more flexibility to innovate, particularly through CMMI, the Innovation Center that we talked about earlier. Um, at the same time, and I referenced this at the top, CMS is going to be adding 1,200 employees. FDA is doing the same. It may not be that number of employees. We're going to have a big staffing up over the course of the next year. The oversight agenda, no doubt that the Democrats, when they come into the House, are frothing to start oversight hearings into every aspect of the Trump administration. That will slow things down and be a distraction to the regulators. It's just a reality, and that's probably a net negative. But there's going to be a lot of change and dislocation, come January next year if the prediction that the House goes Democratic proves to be correct.
Now, so in the few moments we have left, if you and we're listening, obviously many industry CEOs and C-suite executives are listening to us right now at the summit. Um, your concluding thoughts. I mean, you're considered a top level counselor to industry large and small. What do you want
Sure.
to share with them right now?
Yeah. So look, we knew this at this time last year. We doubly know it this year. This administration is willing to break things to pursue its goals. It is reshaping the model of what healthcare looks like. There is a huge focus on outcomes-based payments and outcome-based results, and the administration is willing to pay for successful outcomes. And I think that that's nothing but a net positive. We'll see how these different innovation center models deliver, and if they're actually able to break the historical trend and create successful models. But it starts with bold thinking, and this administration has had that bold thinking. On the legislative side, we've already seen over the last, call it 5 to 10 years, legislative policy making being modest, and I think it will be continue to be so, particularly if we have a divided Congress. The chance of achieving things legislatively will be all the more difficult. Still, you got to try, and either you're at the table or you'll be on the table. FDA leadership challenges, and we're in the midst of that right now. FDA is trying to fill the drug center and the device center, I believe, spots, and having a difficult time finding qualified people who will agree to do that work. That has obviously an impact on drug and device development. And then there are all these other new innovations in science, xenotransplant, brain-computer interface, and all sorts of other amazing, work that we can only do today because of some of the innovations with CRISPR and cloning and a lot of the remarkable achievements over the last 20 years. They will have an impact. I focus on Xeno and BCI as two early leaders in the field, but there's many more to come, and that's what keeps this field so exciting. Holds great promise for innovation, and I hope that we all get to play some part of this, so that we can ultimately, pursue what we're all in this for, which is helping the patients.
Well, David, I know you will be pursuing that on behalf of the health innovation sector. And I want to thank you for joining us today. This is year two, the second anniversary of People and Planet United. I'm looking forward to having you on year three to first of all, to look back at your first crystal ball, which I think was modest. You did achieve your predictions with a great rate of success. You've given us, obviously, some high points to consider. You have given us a cautionary tale of what might happen in Congress, albeit it might have minimal effect on the administrative side of the industry. And I think that's encouraging in some ways for health innovators to sort of say, press on. David Farber, King and Spalding, thank you so much for joining us today.
Thank you for having me. Really enjoyed the conversation.